India's digital public health infrastructure is emerging as a global benchmark, and we all believe that AI will play a significant role in accelerating this transformation. To share the National Health Authority's vision and initiatives in this space, please join me in welcoming Mr. Vikram Pagaria, Director of National Health Authority. Please give him a great round of applause. Welcome, Mr. Vikram. Over to you.
Good morning to everybody. First of all, thank you, Sanjeev ji, Sudhanshu, Shantanu from NASSCOM. We have been participating in NASSCOM's initiatives since a couple of years, and it is always a privilege to be here. In this presentation, I would want to tell you a little bit about the kind of work that the government is doing on digitalization, interoperability, and artificial intelligence. And given the nascent digitalization of the healthcare ecosystem, all these things are going in parallel. The digitalization is also happening, interoperability is also happening, and artificial intelligence embedding in the workflows is also happening. Um, the good thing about India's DPI journey is that we have a solid potential, solid ground based potential on which we are working on. We already have shown how digital public infrastructure in through Aadhaar, through FASTag, through UPI has been developed. It has worked very well in other sectors. So it gives us a lot of confidence that we will be able to do the same thing in healthcare. We also have governance with research and validation ecosystem. So the objective of the Ayushman Bharat Digital Mission, which was launched in September 2021, is to promote interoperability of healthcare information, of healthcare services, and of healthcare claims. And the overall objective, as the leaders had mentioned, is how do we create an ecosystem that supports universal health coverage. And of course, when we think about digitization, we also have to be mindful of security, confidentiality, and privacy, because health data is sensitive. Uh, so the interoperability that we are trying to think about is this interoperability about of healthcare services, so that any citizen can discover any doctor from any interface that they want. This is through the middle gateways, the three gateways that you see, the unified healthcare interface. Then we have the health information exchange and consent manager, which essentially is that suppose you go from Apollo Hospital Chennai to Apollo Hospital Bangalore. Since both of them are on Apollo, you say your mobile number or UHID, your data is readily transferable. But if you go to from Apollo Hospital Chennai to say AIMS Delhi, you share your mobile number or your Abha number, and the doctor says, "Can I see your previous records?" And if you say yes on your phone, you can also select which records you want to show, you want to share, for how long you want to share. The entire control is with the citizen, and through this HIECM layer, you are able to share records. And the National Health Claims Exchange, it promotes interoperability in insurance claims. So if, like, irrespective of whichever insurance policy you have, the Bajaj, HDFC, or ICICI, Star, you go to a hospital, the hospital using your HMIS can directly send your claim to the provider. So the thing that the discharge happens in the morning, that the doctor says the discharge, the patient is ready to discharge, but the actual discharge takes place in the evening, because there are so many paperwork, there are so many inefficiencies in the procedure, in all this insurance adjudication process. They get streamlined through the National Health Claims Exchange. And given the diversity of the country, we don't want any one HMIS or any one software that the hospitals or the clinics or the pharmacies or the labs should use. They have um, they have freedom to use whichever application they want. On the back end, they are connected with these gateways, and they are leveraged. We leverage the ABDM registries as well as Aadhaar consent framework and other already existing infrastructure. Two important things over here. First is presently also like UPI, this is voluntary. What we are trying to do is we are trying to do first it in government hospitals, create value out of digitization. Digitization is all about change management. And the second most important thing is that it's the federated architecture in which this information flows. So the example that I mentioned to you, when the patient shares information to AIMS Delhi, after they go from AIMS Chennai, the information is not stored centrally. It is not stored with the government. When the patient says yes, the information goes from Apollo to AIMS, or the information can flow from my health locker to AIMS. So there is complete um, the complete control over data security in this architecture. This is a snapshot of where we are in the last 5 years. Recently, we have crossed this milestone wherein 65% of our population, that is 90 crore individuals, they have the health ID. They can use this health ID at any healthcare facility. The health ID, they need not remember this 14-digit health ID. They can share their mobile number, they can share their ABHA number, they can share what you also called as ABHA address, like the UPI address or the ABHA number at any healthcare facility, and then it becomes seamless. Also, 100 crore health records have become digital and interoperable, which are because they are linked with ABHA. 90 crore of them come from government facilities and 10 crore from private. Uh, these are the healthcare facilities and the healthcare professionals who are registered. This is basically because when we saw during the COVID time, there is not a reliable database of healthcare professionals, the doctors, the nurses, the pharmacists, the up to date database of these individuals in our country. And similarly, up to date database of different healthcare facilities, public and private, in the country. So we have about 5.21 lakh healthcare facilities. About 2.67 lakh facilities, they use one of the 470 um, ABDM enabled software. They have the freedom to use it. 482 integrators have integrated with us, and their software is being used in 2.67 lakh facilities. Um, we also have something which is called as the digital health incentive scheme, which is basically to promote digitization. We are providing financial incentives to public and private healthcare facilities and health tech companies, those who have created this 100 crore health records. And there is a use case which is called as the scan and share, wherein it is primarily at public hospitals where we see a lot of crowding. So just like McDonald's, where you go, you give your order and you get a token number. Similarly, the patient, they go and they scan their the QR code of the hospital, which is placed. You can see in the second slide, and then they can share all their details. For example, whenever you go to for registration, you just have to tell your name, your address, your mobile number, your demographic details. So the waiting times have reduced to 4 and 5 minutes in public hospitals. We see um, um, a lot of traction in UP, Bihar, wherein significant waiting times have been reduced. So this is an example of how we can change some of the workflows which are inefficient. There are so many workflows, so many inefficiencies in the healthcare ecosystem. Some of the things that this situation can this mission can solve. Again, this example is wherein the doctor writes, take a MRI, take a CBC test, and as soon as the doctor writes or dictates it to the HMIS, you get a prompt on your mobile that you can make the payment to any concerned pharmacy and laboratory. So this is the Scan and Pay initiative, and this is the Model ABDM facilities initiative because I mentioned to you that digitization is difficult, and end-to-end digitization is even more difficult. So some of the hospitals, they are doing registration and they are doing billing, which is digital, but the OPD is all manual. The IPD is slightly digital. So if we can create some model facilities which are end to end digital, and during that journey if we understand how is there some things that we need to take care of, then we can use these principles and apply it as we digitize the entire healthcare ecosystem. The doctors ask, why should I use digital systems? So we have tied up with AIMS Delhi, and there are various health tech companies. So we don't tell the doctor that, hey, you can make mistakes, but we just tell them that if you are using, if you are advising something to your patient, and by mistake, by oversight, you have prescribed some medicines which are contraindicative to each other, or there is some additional thing that you could have written, then you could use the CDSs. And the idea was that they should find some advantage while they digitize, while they use digitization, while they digitize their facilities. I had mentioned to you about this digital health incentive scheme. So for every health record that an hospital creates, they would get 20 rupees per healthcare record, and the healthcare software that I'm using, they would get 5 rupees per record. So these incentives, around 137 crore, we have dispersed. There are government facilities, there are private facilities, there are private health tech companies. So of course we know that the first step when we take for digitization, we'll have to have hardware, we have to have a software, we have to have internet connection. So this is basically reimbursing some of the costs that the facilities want to take, and the solution companies also would make their software affordable and provide to the healthcare providers. This is an example of how the PHR apps work. So we have the ABHA app. We also are revamping the Arogya Setu app, which was used during COVID. And there are presently 19 different private apps. So they will give you an overview of how your health records are there. They keep all your health records at one place. Suppose you are diabetic, then all your HbA1c records, the graph comes automatically, and it gives you smart reports. So, and it will as I had mentioned to you, it will also allow you to give consent based access of your information to other healthcare providers. um, this is just an example of how people perceive what ABDM is. And so ABDM is not a software that is working in a single hospital. ABDM is essentially bringing together all the ecosystem and connecting to each other. And the example that I can give you is that suppose we are 200 people in this room, and if each one of us have to shake hands with each other, then it would be 200 into 199 by 2, which is 19,900. But if all 200 of us place our hands together at one place, then all of us are connected to each other. So with 200 handshakes, with 200 API integrations, we are able to make a digital integrated system, and that is what the digital mission does. The Digital Personal Data Protection Act has also come recently, and wanted to speak a couple of minutes on that. And that emphasizes a lot on a safe and a trustable use of personal health data. And it talks about consent manager. It talks about that whenever you are taking personal data, you have to take a specific consent from the individual. And what we want to say to all the health tech companies, that if you comply with ABDM, if your product is integrated with ABDM, it acts as an enabler for compliance with the DPDP Act, because ABDM also, before the DPDP Act in 2021, had already made its foundation, which has a strong consent framework, and you can use this framework and become compliant with DPDP. As you all know that this year, November 2026, is the deadline for getting compliant with the consent manager framework of DPDP Act. We have also taken various AI initiatives. My colleague Himanshu will speak to you about two specific initiatives that we have launched recently in the India AI Summit. And this is it from our side, and thank you so much.